My name is Dr. Parth Mashrooq and I welcome you all to this continuous cardiac education seminar organized by UNMICRC Institute of Cardiology and Research Center. And today the topic that I am going to discuss is about WPW syndrome, but I will be focusing only on the ECG localization of accessory pathways and how you can easily approach by just looking at the ECG that where exactly the accessory pathways are and what are its importance. So objectives of today's class: firstly, understand the ECG principles of ventricular pre-excitation. So we have heard a lot about pre-excitation in the ECG, but what exactly is pre-excitation? What is exciting prematurely, and how it is happening when there is an accessory pathway? So that concept is very important and it's very vital to localize the accessory pathway using the surface ECG. And once you localize that accessory pathway through the ECG, then you can decipher the strategies for ablation and further management. So what are the basics of WPW syndrome? Core concept is that there is an atrioventricular accessory pathway which pre-excites the ventricle, and risk of having WPW syndrome is that it can develop SVT, it can develop antidromic AVRT or orthodromic AVRT. It can also lead to AF with pre-excitation, which can conduct at a very fast rates to the ventricles and can also lead to sudden cardiac death, which is very rare but it's real. So what is pre-excitation basically? To understand what is pre-excitation, we need to understand the normal conduction system also. So this is a basic schematic animation which I have made to make you understand the concept of normal conduction system. So first of all, the conduction system starts from the SN node. The conduction action potential travels from the SN node to the AV node. There is an AV delay in the AV node because AV node has a decremental conduction property, and after that the conduction signal passes through the His bundle and further through the bundle branches, and it activates both the ventricles simultaneously, and that is why we get a P wave which is followed by a PR segment which denotes the AV nodal delay, and a normal QRS is formed which is narrow. So this is how a normal conduction system works. Now what happens when there is an accessory pathway? So for example, here is an accessory pathway which is an extra pathway between the atria and ventricle apart from the AV node. Normally it is not present, but if it is present, then what happens? Some of the conduction passes normally through the AV node, it stops here for the AV delay and then it conducts the ventricle, but at the same time the action potential also traverses through the accessory pathway. Now the accessory pathway does not have the decremental, not always have the decremental properties like AV node. So as soon as the P wave ends, the ventricle starts exciting. So this is what exactly means by pre-excitation, that when the ventricle is getting excited by the AV node, the accessory pathway leads to pre-excitation of ventricle before the AV node. But now the issue is that there is no conduction system present on here in the ventricles over here. So the conduction, the action potential traverses through muscle to muscle conduction from the ventricles, and therefore there will be a wider QRS. So at the beginning the QRS will be wider, but then the normal conduction from the AV node also excites the ventricle from the normal conduction pathway, and it reaches up to the conduction system passing from the accessory pathway, leading to a slurring of initial QRS followed by normal QRS. So this is what basically pre-excitation means. So if you see the QRS formed, see there will be a P wave and immediate activation of ventricle starts because of the accessory pathway, but it is slow. So the QRS formed will be wider as compared to the normal QRS, but then as soon as the normal conduction reaches up to the accessory pathway, the QRS becomes again narrow and it normalizes in the later part. So this is what pre-excitation is about, and delta wave is basically pre-excitation of the ventricles through accessory pathway before the normal conduction reaches the other part of the ventricle. So now why this is important? So accessory pathway, the location of accessory pathway denotes the direction of delta wave form in the QRS. So basically where the deflection of delta wave is, you can predict the location of accessory pathway through that. And we have numerous algorithms to denote where the accessory pathway is. But if your basic concepts are clear, you need not even remember all those algorithms and still you will reach to an accurate diagnosis. So moving ahead, classic ECG features of WPW is short PR interval, delta wave and wide QRS. All these three I explained with the animation why this is happening. Why short PR? Because accessory pathway has no delay and it immediately starts exciting the ventricle. Why delta wave? Because the ventricle, the part of ventricle which the accessory pathway excites does not have normal conduction system. So the action potential traverses muscle to muscle. So there is a wider QRS at the beginning and then which is followed by the normal conduction. So we are saying localizing the accessory pathway. So why do you need to localize the accessory pathways? So first of all, to plan the ablation better, explain the risk and benefits to the patient. So for example, if there is a pathway which is very close to the anterior septum or his, there are chances of developing AV node block or CHB during the time of ablation. So you are pre-aware of the fact that you have to be careful of the His bundle or the AV node to prevent any complications like CHB, and you can also counsel the patient better that these are the complications that can happen. Another is septal puncture. So for example, if you are suspecting, if your pre-diagnosis in the ECG is left sided pathway, you are anticipating septal puncture. So you have to be ready with appropriate hardware required for septal puncture and also appropriate counseling to the patient and the relatives that this is how we are going to proceed. So anticipate AV nodal injury that I explained earlier. Another one is, for example, there are posterior septal pathways which have higher chances of developing AF with pre-excitation. So you know that if the patient is having pre-excitation suggestive of a posterior septal pathway, the chances of developing AF and leading to sudden cardiac death risk is higher. So even if the patient is not having documented tachycardia, you will still consider the option of radio frequency ablation in such pathways because they can be decremental for the patient if the patient develops AF. And of course, for the fun of localizing, for example, if you are seeing a WPW patient in OPD and you have localized the pathway according to your logic, and then electrophysiology is planned, and if the same pathway comes out to be true, it will be fun. It will be most satisfactory thing. So moving on, firstly, we need to know what are the pathways which are possible. So this is a schematic diagram of the mitral annulus and the tricuspid annulus, and this is more or less similar to what we see on the LAO view during the ablation. So if you can see here on mitral annulus, the pathways which are possible are lateral anterior, left lateral, left posterolateral, left posterior and posteroseptal. The pathways can be into the CS or dilated middle cardiac vein or CS diverticulum. Then coming on to the right side, they can be in posteroseptal region, right posterolateral or right posterior region, or it could be right lateral or right anterior. So the deflection of delta waves will can help you decide where exactly the location of the pathway is, and after that when you perform EP study, it will be easier to go to that specific location and then map the pathway and then ablate. So this is a diagram I want you all to remember very clearly, because even if you don't remember the steps of any algorithms, if your concepts regarding this diagram is clear, you will never go wrong in localizing any delta wave from the ECG. So this is again the mitral annulus, the tricuspid annulus, and this is comparison of these the orientation of these annuli with the ECG leads. So for example, here this is the left sided leads 1 and AVL, 2, 3 AVF are posterior leads, and anterior leads are the chest leads V1, V2, V3, V4 and V5. So for example, If a pathway is on the left side, so the path, if the accessory pathway is over somewhere over here, is on the left side, on the mitral annulus, the delta wave will be opposite to the left sided lead. So there will be a negative deflection in lead 1, which will suggest that the pathway is on the lateral side. Similarly, if the pathway is on the posterior side, be it on tricuspid annuli or tricuspid annulus or on the mitral annulus, if the pathway is posterior, it will move away from the posterior leads and there will be negativity in the 2,3 AVF. So this is the basic concept. If you understand this concept, you can grossly localize where the pathway is, and along with that there are some fixed algorithms also. If you remember those algorithms, again you will reach to the similar diagnosis. So this is again a schematic diagram of the possible pathways. So mitral orifice and tricuspid orifice. So as I explained earlier, on the mitral orifice, the pathways possible are anterior, anterolateral and lateral, and on posterior side there can be posteroseptal, posterior, posterolateral. So the area here, which is the anteroseptal left sided region, here the area is covered by the aortomitral continuity. So there are no pathways possible over here. So this area is spared, and apart from that, if we move on to the tricuspid orifice, there again there will be right anterior, right anterolateral or lateral, and on posterior area, posterolateral or posterior pathways. So if we superimpose that image on the ECG leads orientation, as you can see here, on the mitral orifice and the tricuspid orifice, for example, if the accessory pathway is on the anterior or anterolateral surface, there will be more negativity in the AVL lead, because the pathway, the delta wave will be moving away from this direction. And if the pathway is most lateral, there will be most negativity in the lead 1, because accessory pathway will be here and the delta wave will be opposite to this lead. So the lead 1 will be most negative, and if it is on the posterior area, the negativity will be in the 2,3 AVF region. So this is the main basic concept of localization. Again, in V1 and V2 also is very important, because if V1 is positive, then if the delta wave is positive in V1, then the pathway is most likely on the left side. If the delta wave is negative in V1, the pathway is most likely on the right side. And after that we can see the limb leads and specifically localize where exactly the pathway is. So we will understand the algorithms. I will show you the most accurate algorithms, most widely used algorithms, but before that we need to understand what are the limitations of the algorithms. So first of all, the algorithms work best and most accurate when there is maximum pre-excitation. So QRS should be at least 120 millisecond. Another limitation is that there can be anatomical variability of cardiac position, rotation, etc., where the algorithms won't work accurately. If the patient is having associated structural heart disease or hypertrophy, again the accuracy will be limited. If there is technical variations in ECG recording, if the leads are not placed properly, again the algorithm won't correctly identify the delta wave. Also, correctly identifying the delta wave onset, sometimes the delta wave is very small or very subtle, so we are not able to exactly judge where the delta wave is actually starting and what is the initial direction of the deflection of delta wave. So correctly identifying that is also a limitation for algorithm, and all algorithms have limitations, inaccuracies and exceptions. So the narrower the QRS, lesser the accurate localization. Why? See, if the QRS is narrow, that means most of the conduction is passing through the AV node and very less conduction is passing through the accessory pathways. So in that case, it is very difficult to localize or accurately, properly localize the accessory pathway. So now the question arises, if there is subtle pre-excitation, how to make a delta wave prominent? So if you suppress the AV nodal conduction, so logically the AV node, the conduction is passing through both the AV node and the accessory pathway. So if we somehow suppress the conduction through AV node, then we can increase the conduction through the accessory pathways. So for that there are various methods. One is we can do Holter recording. So during sleep, when the basic heart rate is low, AV conduction is slow, the conduction through the accessory pathway increases, and we can get more better and clear delta waves to localize. Another one is carotid sinus massage, or you can also give adenosine, which we'll see in an example also. When we give adenosine, there will be AV nodal blockade, so more of the conduction will be passing through the accessory pathways. So we can identify the localize the accessory pathways very clearly. And lastly, there is atrial pacing, which is only possible during the EP study, where you can pace the atria at a faster rate higher than the Van-Quebec cycle length of the AV node, so that all the conduction is passing through the accessory pathways, and you can get maximum pre-excitation and localize the accessory pathway better. So these are the algorithms right from 1987. There are so many algorithms which are available, but all the algorithms follow the basic logic that I explained earlier, that if a delta wave is negative in a particular lead, that means the accessory pathway is located at that area from which the delta wave is going opposite to that lead. So for example, if lead 1 is negative, and lead 1 is the most left lateral lead, so the delta wave, if the delta wave is negative in lead 1, that means the pathway is towards the most left lateral area. So that is the main basic concept of how you reach to the localization of accessory pathway, and such algorithms have used that concept only to see. So now, so this is the first algorithm which I will discuss, is Arruda algorithm. We will go in detail of this algorithm when we see the ECG, when we see the examples of the ECG, because remembering these algorithms is a big headache, and it's very difficult to remember all the steps of these kind of algorithms. So if your concepts are clear regarding the localization, you don't even need to remember these algorithms. So we will see step by step application of Arruda algorithm in the further ECG examples. So the important thing to remember about this algorithm is that you have to go systematically from step 1 to step 2 to step 3 and to step 4. You cannot jump to the step 4 directly or step 3 directly. You have to apply and you have to rule out the previous locations to move to the next location. This is another algorithm which is very widely used nowadays, which is called EZWPW algorithm. This is also a very simpler and very more accurate algorithm, and once we will discuss the ECGs, you will understand that logically whatever we think where the pathway would be, these algorithms are following also the same logic. So even if you don't remember this, you can still reach towards the location of the accessory pathway very easily, which we will see by the examples. So this is another algorithm which is very easy to remember and very accurate in day-to-day practice, and we usually use this algorithm to quickly reach to the diagnosis in the OPD. So it has simply said in step 1 that if we look at the V1 lead first. If V1 is positive, it is mostly on the left side. If V1 is negative, it is mostly on the right hand side. And after that, in the step 2, we see the inferior leads. If all inferior leads are positive, then it is mostly on the left lateral side. If 1 or 2 inferior leads are positive, it is on the left posterior lateral side. And if none of the inferior leads are positive, that means if all 2, 3 AVF are negative, then we see V1 to 1 ratio. If V1 to 1 ratio is more than 1, that means V1 is more positive than lead 1, then it is on the left posterior lateral side. And if lead 1 is positive more than V1, then we see lead 2. If there is complete negativity or notched QS in lead 2, then there is dilated coronary sinus pathway, or if there is no notched QS in lead 2, then there is left posterior septal pathway. Similarly goes in the right hand side. We again see the inferior leads. If all 3 inferior leads are positive, then it is on the anterior side, and then we see V3. If even V3 is positive, then it is on the right anterior side. If V3 is negative, it is mostly on the nodohesian side. And if there is no positivity in the inferior leads, then it is on the posterior side, And again, if we see lead V3, if V3 is negative, it is on the right posterior side. If V3 is positive, then it is right posterior septal area. So I know these are very complex, and if you just try to mug up these algorithms, you are never going to remember these and you are never going to reach to the diagnosis. So therefore, I am again emphasizing on the basic concepts of pre-excitation and how to systematically approach an ECG when you see that patient on first time in the OPD. You won't be able to remember which algorithm to use. So if your logics are clear, you can easily reach up to the diagnosis, which we will see in the subsequent slides with examples. So this is the first example. So look at this ECG carefully first. So there is pre-excitation, the QRS is wide, there is clear delta waves in all leads visible. So first of all, what I do generally in OPD is, first of all, I look at lead V1. So if lead V1 is positive, then I will suspect a left-sided pathway. So here lead V1 is positive. So then the next step is that I look at the inferior leads. So if inferior leads are positive and AVL 1 is biphasic and AVL is negative, so this brings me to a diagnosis that it is not a posterior pathway. V1 is positive, so it is on the left side, and 2,3 AVF is positive, so it is on the left lateral area of the mitral annulus. So logically also we can reach up to the diagnosis that this is somewhere in the left lateral region. But if you see lead 1, so if lead 1 is biphasic and AVL is more negative. So if you remember the diagram, lead 1 was the most left lateral lead. So if it is biphasic, that means it is not, the area is not exactly on the left lateral area. In fact, AVL is more negative. So the pathway is somewhere on the anterior side of the lateral area. So this is how logically we can reach up to the diagnosis that the patient might be having left anterolateral pathway. So if you apply the algorithm as well, so step 1 of Aruda algorithm is basically for left free wall accessory pathways. If we go on the step 1, you can see here lead 1 is biphasic or negative. So yes, here lead 1 is biphasic. So we move on to the next part. AVF is positive or not? So if you see here, AVF is positive. So that means the area is left lateral or left anterolateral. Now if we apply the Pembrun algorithm also, we can also reach to the diagnosis where V1 is again positive. Number of positive inferior leads. So number of positive inferior leads here are all 3. So basically the pathway is left lateral. You can reach to the diagnosis by both the algorithms. But practically if you can see, AVL is more negative and 1 is biphasic. So my area of interest would be on the left anterolateral region around 2 o'clock of the mitral annular location. So this was the left lateral pathway which was then successfully ablated. Moving on to the next ECG. This is again AF with pre-excitation. So this is an ECG with a very fast ventricular rate with irregular and wide QRS complex with pre-excitation. So there is maximum pre-excitation present because patient is having AF. So the rate is very high. So most of the conduction is passing through the accessory pathway leading to max pre-excitation. So you can localize the pathways very clearly from this kind of an ECG. So again, by logic, first step is look at the lead V1. So what is lead V1 over here? Lead V1 is positive. Then next step we move on to the inferior leads. If you see inferior leads, 2, 3 AVF are negative. So the pathway is mostly on the left side, that is on the mitral annulus, and it is somewhere on the posterior region. So now where from the posterior region? Posterior septal, posterior or posterior lateral? For that you need to see lead 1 and V1. So here you can see the positivity in lead 1 is more than the positivity in lead V1. So this suggests that the pathway is more in the middle, more towards the septal region. So my diagnosis from this ECG would be left posterior septal region. So now we will see by the algorithm also. So if you apply this algorithm, the Pembrun algorithm again, first step lead V1 positive, yes it is positive. Positivity of inferior leads, any positive inferior leads? No. So number of positive leads are 0. So then after that, what is the third step? We see the V1 by lead 1 ratio. So lead V1 by lead 1 ratio, if it is more than 1, it is towards the left posterolateral region. If it is less than 1, then it is towards the septum. So here uh, positivity in lead 1 is more than V1. So it is more towards the septal side, and you can see that there is negative notching in the lead 2. So there is a possibility of diverticulum in this kind of a case. So after pre-diagnosis of this kind of ECG, first of all, I would during EP study, I would like to take a CS shoot to rule out any possibility of diverticulum, because the ECG suggests that there must be a diverticulum which is leading to pre-excitation. So this is how you can systematically reach to a diagnosis, and also logically also, if you follow these steps, you can easily reach out to the diagnosis and plan ablation better. So this was basically an epicardial accessory pathway. So moving on to the next ECG, this was a very interesting ECG. So here you can see that patient is having tachycardia, and there are narrow QRS complexes. Also there are wide QRS complexes. The wide QRS complexes are becoming irregular also. So firstly, this patient was diagnosed as having NSVT runs, probably from the outflow tract region. But then we suspected that the patient is having palpitations, and the rhythm is irregular with wide QRS. So there is a possibility of pre-excitation with AF. But this was her baseline ECG. In baseline ECG, there was no pre-excitation at all. So now, as I have mentioned earlier, if there is no pre-excitation and you have doubt of having a pre-excitation, how you bring out pre-excitation in a patient? So for that, we gave adenosine to this patient, and during adenosine, if you can see, there is subtle pre-excitation developing in some leads, and if you can see lead AVL, the AVL QRS in AVL has become negative. If you compare it with the baseline ECG, there was no, the AVL was more positive in this ECG, but after giving adenosine, there was no AV block, and instead the QRS in AVL became negative, which led us to suspect a possibility of an accessory pathway rather than OTVPCs. So again, coming back to the ECG. So now, if this is an ECG of pre-excited AF, how will you localize this accessory pathway? So again, we go to by the stepwise approach. We see lead V1. So is it positive or negative? So lead V1 is positive. So the pathway is most likely on the mitral annulus, on the left side. Then we move on to the inferior leads. In inferior leads 2, 3, AVF, all three are positive. So the pathway is most likely on the left lateral side. So only by these two steps you can suspect that the pathway is on the left lateral side. If you want to be even more accurate, you can see lead 1 is biphasic and lead AVL is completely negative. So again, the pathway is more towards the AVL region, which is the anterolateral area. So by this ECG, we can say that probably the pathway is on the left anterolateral region. Again, if you apply the Arruda algorithm, same steps will be applied. See lead 1, it is biphasic. Yes, it is biphasic. Then we see AVF, which is positive, so it is mostly on the left anterolateral or left lateral region. So this was basically left superolateral, and this is during the electrophysiological study and radiofrequency ablation. So this is the image of, this is the fluoro image showing the heart in the LAO position, where you can see that the mitral annulus is somewhere over here. It is located like this. The tricuspid annulus is located like this, and this is the coronary sinus, where the coronary sinus catheter, decapolar catheter, is placed, and we have performed the septal puncture from the right atrium to the left atrium and reached the mitral annular region at about 2 o'clock origin. So if you can imagine the leads, the ECG leads over here, you can see that AVL is somewhere over here, lead 1 is somewhere over here, and 2, 3 AVF are on the posterior region. So the accessory pathway was found to be over here, which is correlating with the lead AVL, and you can correlate this thing in the ECG also, that maximum negativity was there in AVL, lead 1 was biphasic, 2-3 AVF was positive, and V1 was positive, so it was left sided. So the ECG localization and the ablation correlates very well, and we can easily reach up to the exact point of accessory pathway and ablate it better. So this is where the accessory pathway was ablated at around 2 o'clock region of the mitral annulus. Again, I am emphasizing on in today's lecture, my emphasis was not on the theory of the algorithms, because they are very difficult to remember. Even we don't remember. Being an electrophysiologist, we don't remember these algorithms routinely. So if your logic is clear, you can always reach out to the diagnosis without applying any algorithms. So my emphasis for you guys would be the same. Do you understand the concept of delta wave and reach out to the diagnosis, and then apply the algorithm whichever you are comfortable with, and you can correlate your diagnosis with that algorithm. So again, look at this ECG for a while. What you see, first step, lead V1 is positive. Think of a left-sided pathway. Then what is 2-3 AVF? 2-3 AVF is negative over here. So if 2-3 AVF are negative and V1 is positive, so your pathway is most likely on the posterior side of the left-sided region or the mitral annulus. So after that, you see lead 1 and AVL. So the positivity in lead 1 is more than the positivity in lead V1. So the pathway is most likely on the central area, because the delta wave direction is flowing from the center towards the V1. So there is more positivity in lead 1. So most likely the pathway over here would be on the left postero-septal region. So this is how you can grossly imagine where the pathway exactly would be. So again, if we apply the Aruda algorithm, for example, in this case, you can see that if there is positivity in lead 1 or not. No, there is no positivity in lead 1. And what about V1? So yes, V1 in V1 R is more than S. So you can move on to the next step. You can see AVF. Is there a positivity in AVF? No. AVF is biphasic or negative. So it is negative. So most likely the pathway is on the left posterior lateral region. But here in the Aruda algorithm, the specificity of a septal pathway is not very clear. So that's why it's not very accurate for septal pathway localization, and for that the Pembrone algorithm is more better. So if you can see all the steps over here, in the step 2, it says that if lead 2 is negative or not. So here lead 2 is also not completely negative. In the step 1 also, lead V1, there is no R and S. The lead V1 is completely positive. You cannot specifically use the step 1 in this ECG also, step 2 in this ECG also. And if you move on to the step 3, again in step 3, first step is see the V1 if it is negative or biphasic. Again, you cannot apply this step over here. So moving on to the step 4. In step 4, it says that if V1 is positive, it is on the right free wall accessory pathway, which is not completely correct. So you cannot accurately apply any of the steps in this kind of an ECG. So for that, you can see the Pembrone algorithm. So if you apply Pembrone algorithm over here, lead V1 is positive. Yes, lead V1 is positive. Moving ahead, see the inferior leads. Is there any positivity in any of the inferior leads? No. So no positivity in the inferior leads, so 0. Moving on to the V1 to 1 ratio. V1 to 1 ratio is again less than 1. And if there is complete positivity or notching in lead 2, no. So most likely the pathway is on the left posterior-septal region. And even before applying this algorithm, when we discussed that where the pathway would be, we reached to this similar diagnosis of left posterior-septal region. So basic concept can always make you reach towards the correct diagnosis, and those concepts are more clear in the Pembrone algorithm rather than the Aruda algorithm. So this was on the left inferior septal region. So as you can see earlier in the previous ECG, all 4 steps were not correlating with the exact presentation of the ECG. So Aruda algorithm was not very accurate in that ECG. So they have modified this in the step 4, they have removed the positivity of V1. Still we are not able to exactly localize the pathway in that kind of an ECG. So this is the basic shortcoming of the ARUDA algorithm, and that's why Pembrun is much better, because it correlates with the basic logic of accessory pathway and easily reaches towards the diagnosis and the correct localization of accessory pathways. So again, as I've said earlier, we will mostly discuss via the examples of the ECG rather than the theory, because we don't want to remember any algorithms. We want to clear our logic and reach out to the diagnosis without remembering the steps of algorithm. So in this, what we can see is, firstly, lead V1, there is slight positivity in V1, but more of the QRS is on the negative side. So V1 is negative, so I would suspect the pathway to be towards on the right side, or the tricuspid annulus side, followed by which we see the inferior leads. In inferior leads, lead 2 is not negative, but 3 and AVF are negative. So it is mostly on the right posterior area, and lead V2 and V3 are positive. So that means it is not more lateral towards the right side, it is in the center. So most likely the pathway would be right posterior-septal in this region. So again, another concept that I would like to share with you today is that you need to understand one thing. More positive the V1, more leftward the pathway is. More biphasic or negative the lead V1, more rightward the pathway is. And later the transition, it moves further away in the tricuspid annulus. Earlier the transition, the pathway is most likely in the middle or the septal area. So over here there is transition in V2, so it is a septal region, and N3 and AVF are negative. So this is most likely right posterior septal accessory pathway. So applying ARUDA in here, we test the accuracy of ARUDA again. Whether it is left free wall pathway, lead 1 is biphasic or negative? No, lead 1 is positive. Moving on to the second step, is lead 2 negative? No, lead 2 is also not negative, so subepicardial pathway is also less likely. So moving on to the third step, is lead V1 negative or biphasic? Yes, lead V1 here is negative or biphasic, so we move on to the next step and we see AVF. So whether AVF is negative, if the AVF is negative, it is most likely CS os or posterior septal tricuspid annular pathway. So in this ECG, the ARUDA algorithm has accurately reached to the diagnosis of right posterior septal pathway, and logically also we reached to the same diagnosis. So it was right posterior or right inferior septal pathway. So another example, I give you 10 seconds to apply the logic and reach out to the diagnosis in your mind, and then I will give you the answer. So first of all, what I do is look at lead V1, right? So what is lead V1 over here? Lead V1 is negative and lead V2 is positive. So there is transition between V1 and V2. So most likely the pathway is on the right side, but in the middle, on the septal origin, on the septal area. Then we see leads 2, 3 and AVF. 2 is not negative, but 3 and AVF is biphasic and 3 is negative. So it is on the posterior side, but not likely on the epicardial region, because lead 2 is positive. So this is most likely on the right posterior septal area or right inferior septal area. Okay, so if you apply the algorithms again, you will reach out to the diagnosis of right inferior septal region. So now moving on to the next ECG. Again, before applying any algorithm, we see by logic lead V1 is more negative, so the pathway is most likely towards the tricuspid annulus. Then we look at the inferior leads 2, 3 AVF, all three are positive. So the pathway is most likely on the anterior surface of the tricuspid annulus. So if you apply the algorithm, step 1 is rule out, because lead 1 is positive, it is not biphasic or negative, so step 1 is rule out. Step 2, lead 2 is negative or not, so lead 2 is not negative, so it is not a subepicardial accessory pathway as well. And then if you see step 3, here you can see that V1 is biphasic, so we can move on to the next step and see AVF. AVF is also positive, so then the next step is to look at lead 3, which is also positive in this ECG. So therefore the pathway is most likely on the anteroseptal region. So the point to be noted over here is that the location of his is also around this area itself. So during ablation there are high chances of damage to the his bundle, which can lead to AV block. So pre-procedural diagnosis of the ECG is very important, so that we know where exactly the pathway is and what are the risk of ablating, and you can counsel the patients and patient relatives better before the procedure of the possibility of developing AV nodal block during ablation. So this was right superior septal pathway. So probably the last ECG of our discussion. Again, I will give you 10-15 seconds to look at this ECG properly and try to localize where the pathway exactly would be. So what is the first step? Forget the algorithms. What is the first step that we see in OPD? Lead V1. So whether it is positive or negative, V1 is more negative. So where the pathway most likely would be? On the tricuspid annulus. Okay. Next step, the inferior leads 2, 3 and AVF. You can see 3 and AVF both are negative. So pathway is most likely on the posterior area, right? And there is transition in lead 1 and V2. So that means it is the pathway is in the center, in the septal area. So by these clue, we can already say that the pathway is mostly on the right posterior septal region. And if you can see in lead 2, the delta wave, the lead 2, the QRS is biphasic. It is not completely negative or it is not notched. The possibility of CH diverticulum pathway is very less. So this is basically on the right posterior septal region, the posterior septal area of the tricuspid annulus. So now if we apply this algorithm, where do we reach on the diagnosis? Lead V1, whether it is positive or negative, it is more negative. So then we see the inferior leads. How many positive inferior leads? No positive inferior leads, so 0. So then we see V3. So basically looking at V3 is, the purpose of looking at V3 is the transition of the delta wave from negative to positive. So if lead 3 is positive, that means the transition is early. That means the pathway is more towards the septal region. So the pathway according to this algorithm also comes out to be right posterior septal. So even without algorithm, you can easily reach to the localization of the pathway. So this was basically right inferior septal region. So take home message, all algorithms have shortcomings. As we saw earlier, some of the algorithms are accurate for some particular type of pathways, another are accurate for other type of pathways. So the basic important thing is to understand the logic behind localization, and you will never go wrong with the localization of ECGs. Algorithms are most accurate when there is maximum pre-excitation. So if there is subtle pre-excitation, you cannot accurately diagnose where the pathway is. Next, pre-procedure diagnosis is very important to focus on the most probable location. So it's very easier to actually go and map that area if you know the pre-procedure diagnosis of the pathway. Also the risk associated with ablation. If the pathway is near the his, you know the risk of CHB prior hand before taking the patient inside the OT. So that's why it is very important to accurately diagnose or accurately localize the pathway. And if logic of pre-excitation and localization is clear, we need not remember any algorithms at all. So even I don't remember any steps of any algorithms, but if we see an ECG in an OPD and if we apply proper logic of the localization, we will never go wrong on the localization of the pathways, and you can also plan the ablation better and explain the risk to the patient and relatives better if you are accurately diagnosing the pathways. So thank you very much. My name is Dr. Parth Mashru. If you want to reach out to me for any kind of doubts for these kind of ECG or any other kind of ECGs, feel free to reach out to me and I will be very happy to discuss. And I hope you enjoyed this lecture. Thank you so much.